Hello, good morning all. I welcome you all to another exciting session of Grand Rounds today. It's very heartening to see a good crowd here. I also extend my greetings to the robust online audience. My request to all of you is to keep noting down your questions so that you can get interactive at the end of this very exciting session. Well, we all know that the two major neuroimaging modalities of the brain and orbit that we have are the CT and the MRI. But what if our conventional scans do not yield a diagnostic result? Then we may need to do a contrast imaging or go for specialized sequences like the fat suppression sequence on the T1 and the FLAIR sequence on the T2. What if we have to study the vascular structures of the brain and the orbit? Then we may need the vascular imaging like the CTA or the MRI. Let's go a step further. If there is a vascular impediment and we want to evaluate this acute stroke better, then we need scans such as the diffusion-weighted or the perfusion-weighted imaging. If we want to map the functions of the brain, we need the functional MRI. And if we want to pick up those hot and cold spots in brain and tumor metabolism, then we need scans such as the PET or the SPECT. SPECT is nothing but the single photon emission computed tomography. And if we want to look at the spectra of protons in the brain, then we need the MRI spectroscopy. So we have a whole gamut of investigations in our armamentarium. And the more we have, the more we are spoiled for choice, and more is the confusion. So today, to simplify matters, we have a very eminent ophthalmologist with us, Dr. Navin Jayakumar. He's been the past director of the Neuro-Ophthalmic Services at Shankar Nethralaya, and he's currently the honorary director of Darshan Eye Care. He's had a good stint at the Hong University as well, where he has helped them set up the new ophthalmology department. He's the proud recipient of the APAO Academic Achievers Award, and he is on the editorial board of the prestigious Journal of Neuro-Ophthalmology, USA. His personality will not be complete unless I mention his equally relevant other passion, his passion for quizzing. He's been associated with the famous landmark quiz for more than a decade. Apart from all this, NJKSWare has been associated with the simplistic teaching methodologies of even the most complex neuro-ophthalmic disorders. So today, let us explore the world of neuroimaging along with Dr. Navin Jayakumar. Over to you, sir.
Thank you, Manjula, for inviting me here today. I know it's 8 o'clock in the morning and not the brightest of times to look at something as weird as MRIs and stuff, but I thought I'd take that risk and go ahead. And today I'm going to focus not on CTs, but I'm going to focus on magnetic resonance imaging and how we can make sense of these images. So like any imaging modality, you need to have your films and your report. A good viewing box would be helpful rather than holding it up against the tube light. I think what is important is the basic knowledge of neuroanatomy, because you have to figure out what is it that you're seeing. And as far as MRI is concerned, unlike CT, there are a whole host of sequences like Manjula mentioned, and they all produce different kinds of images. So it's also important to know what kind of images you're looking at. And from that, maybe think about when you have a case as to what kind of imaging sequence you need, because it's important for you to interact clearly and informatively with the radiologist, because that interaction is equally important rather than just filling up a form and just sending it. So today I'm going to focus on the different kinds of images produced by the MRI. In the early 50s, the physics phenomenon on which MRI is based is called nuclear magnetic resonance. And in the early days of MRI, it was actually called the NMR machine. But the general public was a little wary about this word nuclear because it is associated with this, and we're not too happy to go into a machine which could also explode in this fashion. So people changed the name and now call it magnetic resonance imaging. So I'm going to risk a little bit of your time, about 5 minutes, to try and explain to you what is going on, so that if you know a little bit about what is going on, you might understand what you're seeing on those films a little better. Because I have a feeling you're not going to listen to this again, or you're not going to read this again, or you're going to run away from this. So I got caught you here, so let me quickly go through this. So this is the MRI machine, and as you all know, if you've seen the Bond films, this has a huge super magnet inside it. Okay, it's a very, very strong magnet. So why do we need the magnet? Let's take a quicker look. So all of you might have read that the MRI is dependent upon hydrogen nuclei or protons, etc. Hydrogen atom, as you know, has one proton and one electron going around it. So this one proton is the nucleus of the hydrogen atom. And like the Earth spinning on its axis, all these elementary particles also spin along their axis. Now, they all spin obviously in different directions. Right now, every hydrogen nucleus in your body is actually spinning like this. But however, they are not spinning in sequence. As you can see, they're all disorganized. So overall, if you look at your magnetism in absolute physical terms, I do not know what your charismatic magnetism, but physically magnetism is zero right now. Okay, because all these spins in different directions cancel each other out. But if you are going to be put inside a magnetic field, what happens is all these little spinning nuclei align themselves to the axis of the magnetic field. Some may be pointing up, mostly pointing up, some may point exactly in the opposite direction, but they all align themselves. It is at this point when you apply this famous radio frequency pulse, which everyone talks about. The pulse is exactly timed to the same speed of the spinning. So it acts like a resonance. And you know what the word resonance is? If you have an instrument tuned at another one of the same pitch, you get resonance. So this 90 degrees pulse is tuned to the resonating frequency of these protons. This causes these protons to get energized. They absorb energy. And when a proton absorbs energy, it flips itself in the direction of the radio frequency pulse. So as you can see, this X, Y, and Z axis, it was originally in the Z axis vertically. Now it is flipped down 90 degrees into the horizontal plane. It is not just flipped down, it is doing something else. Okay? And it is rotating. What do you see about this rotation in this XY plane? All the hydrogen nuclei are rotating exactly at the same time in the point. Okay, so this is called being in phase. Okay, as you can see there, they're right at 12 o'clock at the same time, at 6 o'clock at the same time, they're going at the same speed. Okay, now what happens if we switch off the pulse? The first thing that happens is these excited protons return back to the original state, which is vertical in the Z-axis. And this process, the time over which these certain percentage of protons return back to the original state, is called T1 relaxation. The word we use is relaxation, where it gets back from a high energy state back into its low energy state. So this is T1. But there's something else happening. What about the spinning which is going around in the XY phase? These spins start to dephase. Some go faster, some go slower. And so this is called T2 relaxation, the point at which all these spins stop rotating in unison. Okay. Now, why are we looking at this T1 and T2 relaxation? We are all talking about the hydrogen nucleus. Where is the hydrogen nucleus most commonly found? In which molecule? Water. And water is present in about 70% of your body is water, which is why you use hydrogen in the water as the source, because it gives the biggest signal, because you have a lot of water in yourself. Okay. Now, if I'm saying that hydrogen nuclei are going to behave like this, exactly the same, in a photograph, if you take a black and white photograph, what do you need? You need contrast. Some areas look dark, some areas look bright, and that's how you're able to see images on a picture. If everything was looking uniformly black or white or gray, there's no photograph to be looked at, there's no image. So the basis of any image, whether it's a color or a black and white, is the contrast that we get. So where is the contrast if all the items are going to behave the same and relax at the same? The point is, they behave differently. These timings of relaxation are different. Oh, by the way, let me tell you that when it relaxes, when a nucleus relaxes from a high to a low, it's actually releasing a photon, which is a packet of energy. It is this photon released which is picked up by your MRI machine and then converted to an image. So you're seeing images of photons being released. As in, going back to what I said is, if it's all going to be the hydrogen nuclei, you're not going to get any contrast. But the way these hydrogen nuclei get back to their old phase or relaxing phase is different in different tissues in the body. For example, you can see that in fat, for example, the T1 relaxation time is 300, whereas in CSF, which is in water, it's 4,000. It takes a much longer time to get out of phase because water being purely almost thing, it continues to spin exactly as it is. Whereas in fat, because there are other cells and other things, structures around it, it dephases a lot faster. So as you can see, these numbers, T1 and T2, are different in different tissues. And it is this difference of relaxation which is exploited to create different shades of gray on your MRI image. This is how you get your MRI image. Okay. So let us here see, this is just a pictorial version of what I said earlier. As you can see here, fat relaxes faster after you switch off the radio frequency pulse. Gray and white matter a little later, and very much later is water. Water takes a long time to get back to its relaxed phase, continues to remain excited for a long time. So what happens if after stopping the pulse, I start to take the image acquisition very early on? Okay, just if we take it quick, what all do we see which is bright here? Fat. You can see gray matter and white matter because they're all relaxing, releasing their photons and creating your image. But water is still spinning. It's not releasing any photons right now. Okay, it's going to be dead as far as your pickup of the signal is concerned, which is why in a T1 weighted image, water appears dark. It's still excited phase. It's not releasing any photons. That's why it looks dark. So when many of you may be remembering T1 images, remember fluid is dark, fat is bright. T2 images, fluid is bright, fat is, that kind of a thing. So you can see that at the bottom, if you look at an MRI full, you'll see the TR, which is the repetition time, and the TE, which is the echo time. The echo time is the time in which you take the picture. Okay, so these are very short, 14 milliseconds and 450 milliseconds. Contrast this to what happens if we take an image much later. When you take a much later, what is it that is really bright now? It is the water that is reading. The fat, everything, the nuclei have already completely relaxed and gone back to their completely relaxed state, no more photons to release there. So this is the basis of the T2 weighted image. And now you can see instead of 14 and 450, you have 105 and 5,500 milliseconds in the column there. So these are very long repetition and echo times. So this is the basis of the T2 image. T2 image is therefore image favoring water. And the thing is, water is found a lot in pathologies, whether it is edema or ischemia or inflammation, whatever. There is always an excess of fluid happening. And that is why T2 images are very useful for pathological things. You want to see pathology, look at the T2 images. Okay? So let's get back. That is the end of my physics, more or less. So here's something that's more familiar to you. This is a patient with right optic nerve, and he had a right optic neuritis. So what you've taken is you can see the label T1 and weighted and T2 weighted. On what basis can you tell me that that is a T1 image? Any idea? Why do you say that is a T1 weighted image? CSF is? Okay, so good. So if you can see just below the words T1 weighted, you can see a ventricle and the fluid inside is dark. You can also see the fat in the orbit is also extremely bright. Okay, so this is a T1 weighted. Why is this T2 weighted? You can see the vitreous is glowing completely bright. Now the fluid is, water is releasing all its signals, so you get a bright. If you want to be a little more technical, you can look at those numbers below. You can see the echo time is 15 and 425 is repetition. Here echo time is 100 and this is in the thousands. Okay, so that itself will tell you if you want to be one step higher and impress your examiner, you can tell them it is long TR and TE times as well. Okay, but this is good enough for us to see. So here you can see the iso-intense optic nerve on the right eye. Okay, and here you can see a hyperintense. So the words we use, if you remember in CT, we use the word hyperdense and hypodense. Here we are referring to signal strengths. So we use the word intensity of the signal. So it can be hyperintense or hypointense or isointense. Okay. So these are the words that we use. The word iso refers to what? Hyper, hypo, and iso refer to you're comparing it with something. What are you comparing it with? You're comparing it with the gray of the brain. So anything that is brighter than the gray shade of the brain substance is called hyper. Anything that is looking darker than that shade of gray on the brain is called hypo. Anything which is looking the same shade, as you can see that optic nerve and the brain are looking the same shade of gray, that's called iso. That applies to even CT as well. So you use isodense, hyperdense, and hypodense. Here you use isointense, hyperintense, and hypointense. Okay, so let's get on to what we can do next. For example, if you have this patient with optic neuritis, we use something called contrast agents. The most common contrast agent that you may have come across is gadolinium. So gadolinium, if you may have read, is described as a paramagnetic agent. So on its own, gadolinium is not magnetic. But when you put it in a magnetic field, it acts as a small magnet. Every molecule of gadolinium behaves like a tiny magnet there. So you can therefore understand that you have this magnetic field in which these things are spinning, which is why they don't want you to bring any other magnetic object into the MRI machine, because it's going to upset not only it's going to drag you along and fix you to the machine, okay, dangerously, okay, that's the Bond film, but it can otherwise interfere with the acquisition of images. If you take a magnet inside along with you in your pocket, okay, even if you're not attracted and stuck to the machine immediately, it's going to create confusion and you're going to get bad images. Why? Because this magnet which you introduced on the side is going to interfere with the overall magnetism which is in place. It's like you have introduced, I am talking to you, all of you are looking straight at me. I'm going to introduce some comedian here, okay, in between to create some confusion. The moment someone makes a joke, what's going to happen? You're going to start laughing, I want to look at them. And so things are going to get disrupted. Okay. Imagine all of you in phase, but I put something disrupting in between. It's going to go out of phase much faster, which is why gadolinium hastens the relaxation time. It makes it a lot faster. That relaxation speed of T1 and T2 go a lot quicker if you introduce a little magnet into that area. How does gadolinium enter? Through your blood, because you inject it. So where is it going to get past? Blood-brain barrier if there is a disruption of the blood-brain barrier. So once again, wherever abnormal fluid is collected, gadolinium is also going to enter there. It is going to therefore shorten the relaxation times. So if you take a T1 image, which is already a short thing, you're going to get increased brightness there. So here is the same patient. Here you can see what tells you that this is a T1 or a T2 image.
The vitreous.
The vitreous. Vitreous is what color here? Dark. So that means what image is this? It's a T1. So you can also see below 525 and 20. So this is a T1 weighted image. So all contrast films are done, sequences are done on T1 weighted, because you want to capture the quick relaxation produced by the gadolinium and not wait all the way for water. We are not interested in that part of it, right? Okay. So we want a very short window by which you take your images. So you take advantage that gadolinium creates in those abnormal areas. and heightens the contrast there. So because of that, you can see the increased signals contrast enhancement from the middle to the posterior intraorbital segment of the optic nerve, that side on the right. Is there any other pointer, simple pointer, that may tell you that this is a contrast image? Couple of other things. The most common one is, can you see those little dots here? Can you see those dots on the screen? Can I show this here? This one, for example. Okay, and there are some others here as well. What are these? These are blood vessels. These are tiny blood vessels carrying blood and therefore also carrying gadolinium. And therefore they enhance. So if you see a T1 image with little blood vessels dotted over it, then you know that this is a contrast image. So in case someone just puts up a film and asks you, this is how you would be able to make out a contrast MRI. Also, if in case it is an orbital MRI, you can always see enhancing extraocular muscles. Extraocular muscles always look very bright. Look at it. Okay. So the other thing, the next sequence I'm going to talk to you about is again something that you will see on your reports, which is called the inversion recovery sequences. So you may get words like this or acronyms like that. MRI protocols are full of various acronyms. Okay, so STIR stands for short T inversion recovery. FLAIR stands for fluid attenuated inversion recovery. But there are two letters which are common to all these, which will tell you this is an inversion recovery sequence, which is the letters I and R. Okay, that tells you. So the purpose, why do we need these inversion recovery sequences? No physics here, but the idea is you suppress signals from water or fat. If for water we use FLAIR, which is fluid attenuation, and for fat you use STIR or SPIR. STIR is short tau inversion recovery, but we don't need to know all that. The question is, why do you want to suppress water or fat? As I told you again, the whole basis of any image is contrast. One area looks darker, one area looks brighter. That's how we see pictures. So how do we heighten that effect here? So here you can see on a T1 weighted image. How do we know it's T1? Look at the water there. Okay. You may be wondering why the fat is looking bright, because again it's a T1 weighted image. Okay, it's enhancing. In this T2 weighted image, you can see, how do we know it's T2? The water is bright, but you can also see the optic nerve, which is looking bright. The optic nerve is looking hyperintense because the fat around it is being suppressed. So the fat doesn't look too bright. We try to make it as dark as possible. Okay. In a normal T2 nowadays, the fat will also actually look bright because they take multiple sequences at the same time. Your MRIs are not like the old ones. While even one is going on, the next signals are going. So they do multiple sequences together. So because of the constant simulation, even fat starts to look bright. So the best thing for you to differentiate T1 and T2 is just look at the water. Water dark is T1, water bright is T2. Okay, don't look at the fat. Okay. So fat tends to look bright in T2 also, and in T1 as well, T1 and T2 on modern MRI sequences, spin echo sequences. So it's good to suppress the fat. The moment you make the fat dark, what stands out in front of you? That optic nerve, which is hyperintense. So that is how you can see this same patient with the optic neuritis. Okay. So we use inversion recovery sequences here. You can see there the word SPIR is there. So you can look at that as well. So here, for example, you can see a T2 weighted image of the brain. Clearly, you can see the, how do we know it's T2? Because the water is, CSF is bright. Would anyone like to comment on anything else that you see there in that image?
The gray and the white matter.
Not you. Gray and white matter you can see. Okay. Anything else? Okay. Let me give you a clue and tell you, imagine in your head, if you can switch off all the white, bright signals from water, imagine in your head. I will show you physically now, but imagine if you didn't see, if all the water looked dark, is there anything that might be visible? No, not visible. Yes.
If there is a periventricular white matter lesion, that you can make.
So let's switch off and see. She says there's a periventricular lesion. There you go. Okay. So if you switch off the signals from the water, what do you see now? This is a classic MS periventricular plaque. This is the reason why we use FLAIR images of the brain. Okay. Suppress the water signals from the normal water containing structures such as CSF. So this is a good example of how FLAIR sequences are important to us. Okay, so this is something you may not have heard, okay, but in neuro-ophthalmology we do use it occasionally. These are called CISS or FIESTA sequences. Basically, these are there to look at cisternal segments of your cranial nerves. We are interested in 3, 4, 6, 5, and 7. Okay, 2 we can see anyway, it's quite large. But these other nerves are very thin. You know, you have Tewson's nerve, your trochlea, these are not only just long, but they're also extremely thin nerves. The oculomotor nerve isn't much thicker than that. So what this does is, what is in the system between the brainstem and your cavernous sinus is CSF. Okay, when your nerve leaves the brainstem, it's going to travel through the CSF and then reach the cavernous sinus, where it's going to enter the cavernous sinus. So now, as it is crossing the CSF, a lot of things are along the way, usually blood vessels. As you know, the third nerve goes between posterior cerebral, superior cerebellar, and lies next to the putagon. All these things are also there. So what these images do is, they make the CSF extremely bright. Okay, super bright. So you're looking at a completely white background, and then you can see this thin line. If you had a white board here and I drew even the thinnest black line on it, it would be visible to you. Okay, so that is the basis. Not only that, these are very thin sections, and because they take very thin, normally the sequences which they take for usually the brain are about 2 to 3 millimeters. I mentioned that, but these are sub millimeters, 0.7, 0.8. sections, so very thin sections. Because they're very thin sections, you can actually reformat these, take the data, you can actually look at it not just purely sagittal, coronal, or axial. You can angle it and say, I want an oblique sagittal. So you can go exactly along the length of the nerve. The nerve is not going to go straight. The nerve goes this way and that way and then maybe turns. But you can actually get the entire nerve along the way by tilting it, by using the data that you picked up. For getting good data, you need finer sections. So this is the basis of the CISS and FIESTA. I'm going to show you one example. So can you see the third nerve there? You see cranial nerve 3. So when cranial nerve 3 actually enters the cavernous sinus, we normally understand it as it enters the cavernous sinus lateralward. The topmost is 3, 4, V1, V2. Okay. So when it enters, it just doesn't enter. There is a fold of dura with CSF which goes along with it. It is encased still. Okay, that entry of that fold is called the porus, which you see there. Can you see that? And then the fold continues right through. That's called the oculomotor system. So let me show you some pictures. So here you can actually see, this is a CISS image. You can see how bright the CSF is in that space there. Okay. And next to that, the black line is the third nerve, which is going up here. Let me use this pointer. This is the third nerve, and this is the entry into the cavernous sinus. But what can you see? You can see the CSF going all the way through. Can you see that? This is the oculomotor system. Okay, so you can see the oculomotor nerve is not going on its own. CSF along with it. Okay. Okay, so I'll show you this. This is what is an axial section. Okay, so this is a coronal section. So here you can actually see the 2 oculomotor nerves in the arrows there, and around it, can you see a white ring? That is the CSF around the oculomotor nerve. And this section is very useful if, for example, sometimes oculomotor pathology results in thickening of the oculomotor nerve. So in this kind of section, you can actually compare one side oculomotor nerve, left versus right. So you can see relative thickness and size. So all these very subtle findings can be picked up. Okay. And here it is. This is a reformatted sagittal image. As you know, the oculomotor nerve comes out of the brainstem and goes up in that direction to the cavernous sinus. But here you can actually follow the entire section because the reformatting goes along the nerve. So you can see the nerve as a straight line. Okay, right from where it's leaving the interpeduncular system, this end, which is here, and this is the cisterna segment of the third nerve. This is the entry here. It's going in here. You can see the CSF going right through to the anterior canal. Okay, so these are images. Now let me show you something very practical which we have seen that I took from an article, but this is a patient who had hemifacial spasm. Okay, so can you tell me what the question mark is pointing to? So what you're seeing is an axial section of the brainstem at the level of the pons. Okay, so right in front of the pons here, this is the pons, and in front of it is the clivus, okay, which is the bone. So you can see the internal auditory meatus there. Okay, so what is this? You can even see it here.
The seventh nerve.
Yes, so that is the seventh cranial nerve. And what is interesting is you see this seventh cranial nerve is fine, but there's something odd going on here, which is basically there is an anomalous vascular loop. So this is the nerve. Okay, this is the nerve, but next to that is this vessel, which is looped. Can you see that? That one. That is actually touching the nerve. And these pulsations of that are what is causing the nerve to get irritated, resulting in spasms on that side. So quite often, if you do MRI, so when you have a hemifacial spasm now, don't just ask for an MRI with MRI angio. Ask for CISS images. Okay, in the interventricular, in the CSF, in the CT angle area, you can sometimes pick up this as well, and you will know why the patient is having a hemifacial spasm. Okay. Coming to MR angiography, so all of you have heard of an MR angiography. So here is a little cartoon. So we have brain tissue, and let us say in the brain tissue there is a blood vessel which is going across. Okay. So in our MRI sequence, what do? We select a slice and say, I'm going to study this section of the brain for this. Then we move on up and up and up. What does it do? It stimulates the brain section with that radio frequency pulse, and this entire thing gets stimulated. All these hydrogen nuclei go to the excited phase, etc. But by the time, remember, there is an excited phase, and then you switch off the radio frequency pulse here, you switch it off, and then everything relaxes, and you get signals. But what happens? Brain is where it is. It's giving out signal. What happens to that blood inside that blood vessel? Between the time you gave the stimulus, second picture, to the time you took the images, the echo time, this blood is not remaining where it is. This blood has flowed here, out of your slice. And unstimulated blood is now sitting where it is. And that is not going to produce any signal. Okay, so these kinds of effects, there is this effect and there's another kind of thing where it can actually enhance the image of the blood. So these things are called time of flight effects. So sometimes you may see the word 3D time of flight MRA, TOF MRA. This is what time of flight we are talking about. Okay, it's a movement. Basically, the principle is blood is moving. So blood is moving through a section. It's not going to give you signals, or it may give you signals depending on how you manipulate the images. So here, for example, you can see fast moving blood therefore always looks black on an MRI. So whether it is a T1 image or a T2 image, you can see there the right internal carotid artery, the basilar artery, you can see that there. Okay. Can anyone tell me what's going on the left side? Look at the right internal carotid. Look at the cavernous sinus. This is the cavernous sinus area here. This is the right internal carotid dark. What is this here?
Like an aneurysm.
Of what? Internal carotid artery. Okay, so you can see this large aneurysm of the internal carotid artery. As you can see, it looks dark on T1 and T2. So that tells you it is a blood vessel. Okay, so these are called flow voids or signal voids. One important difference between MR angiography and your classic digital subtraction angiography or even your fluorescent angiography. How do you do fluorescent angiography? You're injecting dye. In DSA, you're also injecting dye. The dye is passing through the blood vessel. Okay, and therefore you're actually seeing the blood vessel walls because the blood is flowing through that. Here, this image that you see, this is a patient with a 6th nerve palsy on the left side. As you can see, when she's looking to the left, the right eye adducts well, the left eye doesn't adduct well. So this is an MRI, and you can see a very large internal carotid artery aneurysm. Same patient which you saw earlier with a flow void, okay, intracavernous. Now, this kind of time of flight or MRA, the lines that you see here, are they blood vessels or not? All those who say that they are not blood vessels. Yes? Yes, so this is not an image. MR angiography is not an image of blood vessels. It is an image of blood flowing. It's an image of something flowing in on the section. Okay, so you can therefore imagine, unlike maybe a fluorescent angiogram or a thing, when you see that, that is actually a blood vessel. Here, you're saying this is an image of something moving in the brain. The only thing moving in the brain is blood, and therefore this must be the blood vessels. But what happens, for example, if there's a thrombosis somewhere in a vein or an artery is thrombosed? In an aneurysm, you can get thrombosis. The blood flow will be slow. Then will you see the aneurysm? You may not. So the MRA is very good. It picks up almost 98% of aneurysms. But please remember, one of the things it may not pick up is large aneurysms with thrombosis inside it. May not be showing on an MR angiogram. Okay, so please be careful. This is not an image of blood vessels. This is an image of moving blood. If the blood movement is slow, you're not going to get a signal. Okay, certain areas may look normal. Manjula spoke about diffusion. This is one of the areas. Now we're moving slightly from anatomy to functional. Okay, so what is diffusion? If you remember in physics, Einstein, one of the early Nobel Prizes he got was for something called Brownian motion. Okay, whereas basically particles or atoms or protons, they don't stay in one place, they're constantly moving. Okay, so like that, if there is a large pool of water, you have this molecule of H2O there, and it's able to move nicely in all directions. Okay, it's like this room with only one person in it can move around. But in the same room now, with a whole lot of chairs and furniture, your movement is going to be restricted. Okay, it doesn't move that much. Imagine now, instead of all these chairs, I put 3 cupboards and a couple of other things as well. Your movement is going to get even more restricted. Or on the other hand, maybe 15 of these chairs were damaged and they have been removed. Now you created a little more space, so your movement can increase. So depending on the environment in which a molecule of water is sitting, its movement can go up, more diffusion or less diffusion. And this difference is used in what is known as diffusion weighted imaging. The word weighted is you're giving preference to it. Okay. So this, for example, is in the brain damage. You can see from the previous one, those 2 axons have disappeared. Some of the cells have disappeared. There is more space. There's more movement of water, which is possible area of increased diffusion. So here, take a look at this patient with bilateral PCA infarcts. Okay, so cast your eye to the back of the bottom of the image there. That is the occipital lobe. You can see on the left side There's a hyperintense whitish area there. On the right side, it's looking a little patchy. Right at the occipital pole area, there are some areas which are looking brighter, some are looking darker. Then little anterior to that, there's an area of a whitish looking patch there. So this is the FLAIR image. Okay, how do we know it's a FLAIR image? Look at the fluid in the ventricles. Okay. Now, this is the diffusion weighted image of the same patient. Compared to this, there is one thing which is very contrasting now on the occipital pole. On the left side, that area which is looking bright signifies decreased diffusion. When will there be decreased diffusion in an area? If there is edema, tissues are swollen. If these chairs were double their size, there's going to be less space for you to move around. So swelling will result in decreased diffusion. This means that this is an acute infarct which is going on right now. On the other hand, if you look on the opposite side, there has been loss of cells, tissues, etc. There's more space for water to move around. There is increased diffusion on the other side, which means that it is an old infarct. So this is the advantage of diffusion weighted imaging. Areas which pathology which is not very clear can be visualized. So which is why it's used very often in strokes to differentiate early onset strokes, etc. So these are two different patients showing diffusion weighted image. As you can see, they're very simply, even if you don't know anything, you look at the picture, you can clearly tell that these are abnormal areas, large white patches. Okay. Now I'm going to show you a different kind of a scan of the same two patients. Okay. So this is a right middle cerebral artery infarct, and on the other side is a left PCA. Same patients. This is a perfusion weighted image. It's basically telling you how much of blood is actually perfusing those tissues. Not MR angiography, which is large vessels. This is at the tissue level, how good is the perfusion? So this is what you use in technetium and stuff for. Okay. So this is perfusion weighted. If you look on your left side, that same area of the right middle cerebral artery infarct on the diffusion image, you can see the same area here, which is affected, looking dark. Okay. So there is a match between the diffusion, the pathology, and the flow. Okay, so that means this thing is completely blocked. Okay, whatever vessel went there and got blocked, it damaged that whole area. There's no perfusion, diffusion showing the same area damage. But what about this side? On the diffusion image, all you can see is this occipital area and maybe one little area here. But if you look at the perfusion image, that entire hemisphere is having lack of circulation, which means the other areas here which are looking normal are actually having less blood circulation, less perfusion happening. There is a mismatch between the diffusion and perfusion, which means this kind of patient will really benefit from quick thrombolysis, because you know this stroke is going to get larger if you don't do anything about it now. So now is the time to act, break the thrombus. Okay. Whereas on that side, it's already fully developed. There's no difference between diffusion is less, but the perfusion is doing more damage. That these are areas which are suspiciously going to tip into complete strokes. There's nothing like that happening. Those things match. Thrombolysis isn't going to work. So here is an example of doing diffusion, perfusion, combining them together, and you can make a real impact in terms of management plans. The last, which you mentioned, is MR spectroscopy. We spoke about hydrogen and MRI using hydrogen, and the most common molecule of containing hydrogen in our body is water. But is water the only molecule that contains hydrogen? No, because there are a whole lot of other molecules, especially in your brain, which also contain hydrogen to lesser degrees. Okay? And they are lesser concentrated than water, but they are present. So here are some examples. What is the importance of us choosing these examples? Okay, so these are common brain metabolites. What is choline used for? Choline is used for your cell membranes. Okay, So if there is an increase in choline, for example, it would mean there is more cell membrane formation, which therefore means how do you get more cell membranes?
Hypercellular tumor.
Exactly, you're getting more cells. Okay. Creatine is a marker for cell energy. You already know that. So if your creatine is being used up faster, that means what? That means more active cells are present. Okay. So likewise, when does a thing shift to lactate? Anaerobic. That is something which is outstripping its blood supply. Okay. Lipid. When you get lipid, when cells get destroyed, all that choline, etc., breaking down will produce lipids. Okay. So that's a marker for brain necrosis. Okay. So here is a story of two different patients with two different lesions which are ring shaped. Okay. So generally, ring shaped lesions are: is it an abscess? Is it a malignancy? Is it a demyelinating? Occasionally. So here is the one patient. This is the case 1. So this is case 2. So here you can see, I think this is case 1. But the point I'm trying to make is, you choose the lesion. You can see the ring lesion there. You put a marker on it. Okay. Measure the amount of metabolites in that area. Then move the marker to the opposite side. Same area, normal side. Pick up how many metabolites is there. Compare the two. That will tell you how abnormal things are. What kind of image are you going to get? Are you going to get a nice picture like this? No. MR spectroscopy doesn't produce images. It produces a graph. Okay. Helpfully, the radiologist will explain all that to you and mark it out for you, so you don't need to worry. But those different levels of choline, creatinine, N-acetyl aspartate, and lipid lactate are those peaks which you see there. Now here is the patient with that ring lesion there, right occipital area. You can see the choline has gone up, hypercellular area. Creatinine has gone down, lot of energy being used up. Lipids and lactates have gone up. It's gone into anaerobic metabolism. It's outstripping blood supply. There is necrosis also happening. So what causes increased cells, increased energy, lactose, necrosis is obviously a malignancy. So this patient has glioblastoma multiforme. So this is how MR spectroscopy can be useful. And this happens to be my last slide in summary. Okay, we're going to quickly through 5 minutes. T1 weighted image, as you can see there, that's a pituitary adenoma. What does it show very well? It shows anatomy. Okay, so if you want to look at anatomy of that area, look at your T1 image. How do we know it's a T1? Look at the water. Water will look dark. On a T2 image, water will look bright. It shows up pathology very well. So if you want to look at pathologies, a demyelination, whatever it is, all that will show up well on T2 images because T2 shows water. Contrast images, how are they? They are basically done on T1 images. So you see that. And look at the vessels, look at the atrial muscles. They will tell you that it is a T1 image. And so it's used for active lesions like acute optic neuritis, MS, and these kinds of things. Okay. So the fluid attenuation, inversion, the inversion recovery sequences, STIR and SPIR, these are used in orbital because they suppress fat. Okay, so you can see the pathological optic nerve, and you can also use it for certain other areas where there is fat, for example, bone marrow, skull base, and things like that. Okay, FLAIR images suppresses fluid, in this case CSF. So very typically demyelinating disease, your MS plaques would glow literally on the screen. Okay, diffusion weighted images perfect for early stroke diagnosis where you need to make decisions. Okay, it's an axial image. Always, and it looks slightly out of focus as you can see here. That's a kind of a unscientific clue as to this is a diffusion image, and some areas look a little brighter as you can see there. Okay, so think about it for strokes. MR angiography, please remember this is images of blood flow, so we use it for aneurysms and AVMs. Don't forget to use it for any cranial nerve palsy. When you're doing an MRI, you have to ask for an MR angiogram as well. Okay, so the common uses are all these vascular conditions involving these cranial nerves. Okay, MR venogram, most commonly we use it for one thing, which is idiopathic intracranial hypertension, because some of these patients may have occluded or blocked dural venous sinuses. For example, here you get a hyperplastic transverse venous sinus producing a raised CSF pressure and papillary edema in these patients. Okay, so generally when you do an MRI for papillary edema, please ask for an MRI with MR venogram as well. CISS and FIESTA images, as I told you, these are heavily T2 images. So thin lesions, neurovascular lesions involving your cranial nerves in the CSF spaces, use this. And MR spectroscopy finally shows biochemical changes. Unfortunately, that little voxel marker that you see there, it's too big to be used in orbit. Because it would be great if you can put it over an orbital tumor and it tells you what the tumor is. Okay, but we can't do that because the orbit is a little too small and the readings won't come out very accurately. So it can be used right now for the brain. So multiple uses there as well. So on that note, thank you very much.
Wonderful, Professor. I think it cannot get more useful than this complicated topic like an MRI. So the house is open to questions. Are there any doubts?
We have an online question, ma'am.
Right.
Any clue from an MRI scan which tells you that a CT is needed because of a possible bone-related lesion like a cholesteatoma?
Yeah, so it depends on the kind of lesion that you're looking for. So CT, as you know, MRI, bone does not contain much of water in it. Okay, so MRI doesn't really show bone very well. So we can't image bone very clearly. This has its disadvantages and advantages as well. The disadvantage, therefore, is if you're seeing a patient with maybe an orbital fracture, MRI won't be very helpful in telling you where the fracture is, whereas CT, which is based on X-rays, will show you the fracture very well. Okay, so anything that involves bone, so choroidal, for example, osteomas, fibrous dysplasias. So these are things which can show very well on the CT. Sometimes neurosurgeons would order both a CT and an MRI because both give different information. For example, when planning a pituitary adenoma surgery, the neurosurgeon may want to know the position of the internal carotid artery with respect to the pituitary gland because it's going to be working very closely there. So the MRI will be very useful there, and MRA will be very useful there. On the other hand, he may also want to know the bony structures which he has to enter to get to the pituitary gland as well. So a CT is also therefore useful. So depends on the clinical situation. If you're considering a bone or a bone-related lesion pathology, you must do a CT. Now this whole disadvantage of MRI not showing the bone has an advantage. Can you tell me in which area of interest to us? Orbital apex of the orbit guy at the back. Obvious. So in the orbital apex, as you can understand, the space is very small. It's a narrow structure with bones on both sides. Okay, so soft tissue is not clearly seen there on a CT because you have this white bone here and another white bone structure there, and this tiny little bit of gray soft tissue is going to get blurred out. Okay. On the other hand, an MRI is not going to pick up bone signals at all. So only the soft tissue area is very, very clearly visualized. Okay, so areas where there's a lot of bone and you don't want to see the bone, for example, skull base, for example, MRI is not more useful than CT.
Any other online questions?
No, online questions.
Anybody from the audience? So I just want to ask you, because a lot of us keep ordering neuroimaging, what would be the guidelines to order a neuroimaging? General guidelines. When you write for a let it be an MRI, what will be the guidelines that you have to follow when you order a neuroimaging?
Okay, so I think the most important thing is, I'll give you an example. If I told you someone dropped their earrings somewhere in this room and told you to go search for it, it's going to be quite a job. Okay, looking for something small in this whole place. Whereas Manjula told me she sat in this chair And when she got up and went out and she found it missing, where would one likely look? One wouldn't look there. Okay, one would look here. Okay, at this point. So please give relevant clinical information to the radiologist to allow them to focus on areas where they should be looking. Otherwise, with those 3 millimeter section, and you're going to say patient has something, MRI brain, no clinical information. Which area of the brain to look at? Okay, so give relevant clinical information. It's also helpful if you know a little more and say, can you give me a CISS image in case of a hemifacial spasm? I'm interested if there's any vascular anomaly in the CP angle near the 7th nerve. Then they automatically, even if you don't know the name CISS, they'll at least make that effort to look at it then. Okay, so you have to do, for example, you also have to tell them, like, many patients I find who've been referred to me with papilledema have the MRI done. No MR venogram. Then you have to send them back again and get the MR venogram and take a look at it. Okay, so third nerve palsies. Third nerve palsies, radiologists are a little sharper. They know when you refer any cranial nerve palsy, they will automatically do an MRA even if you've not written it. But I think it should at least make them interested, know that you're interested, and if you write an MR angio also with it, it will be great for them. It will make their boring day a little more interesting. Okay. But the other thing I found personally useful is if you have a rapport with your radiologist, if you can pick up a phone and tell them a little more, there's nothing like talking person to person, you get a lot more clinical information as to what you're thinking about and which area should they be focusing on. For example, cavernous sinus. Cavernous sinus, even on an MRI, has very, very subtle pathological changes which you can see on the screen. So even those subtle things, if you do 3 millimeter sections, you're going to miss the whole thing. So if you tell them, look, third nerve palsy, but I think it could be in the cavernous sinus, they will take 10 sections there and look at it as well.
Excellent, sir. So let's look at acute isolated third nerve palsy. There's great relationship between acute isolated third nerve palsy and an MRI and MRA. I'll just give you 4 situations and tell me like how you go about it. Let's look at an acute complete third nerve palsy, which is pupil sparing.
Okay, in that case, MRI depends on the age.
Let's say he has vasculopathic risk factor.
Okay, so middle-aged person, say diabetic with an isolated complete third nerve palsy with complete pupil sparing, I would say wait, no need to do an MRI.
Let's look into the next situation. Acute isolated complete third nerve palsy, pupil blown, complete pupil blown.
Yeah, so any, whether it is isolated or complete or incomplete, if the pupil is involved, by pupil involved I mean anisocoria is present, a mid-dilated or a sluggish pupil, MRI plus MRA is mandatory because definitely there is a pathology going on somewhere. It is aneurysm or cavernous sinus, whatever it is. The other thing you mentioned therefore is incomplete. So suppose, for example, superior rectus and LPS are not so badly affected. Medial rectus, some movement is there. Inferior is affected more. So this kind of patchy involvement, you've seen a complete third nerve palsy, diabetic, no? Total ptosis, nil elevation, nil depression, nil adduction, abduction is full. Okay. Compared to some movement are little more movement there, more restriction here. These kinds of patchy involvement, even if the pupil is spared, should suggest some kind of pathology, and you should do an MRI with an MRI angiogram.
How long would you wait for doing? Suppose your MRI is not showing a non-aneurysmal cause, and your MRA is not showing an aneurysm either. How long would you wait to do a catheter angiography? Because you have an involvement, you have a third nerve palsy, your pupil is involved, your non-aneurysmal cause is not there. You neither have an aneurysm showing up on your MRI. So how long are you going to wait for a catheter angiography? Because there is something still happening in the brain and the patient is having a
So the thing that could be happening could also be infectious, it could be inflammatory, it could be demyelinating. So there are all sorts of other things.
Small aneurysm.
Or it could be a small aneurysm, yes. So what would I do? Current day MR angiograms are very, very accurate, fairly accurate. DSA is still the gold standard. You can still miss a tiny aneurysm somewhere. But by and large, if you find a normal MRA, I would consider doing blood workup and treatment with systemic steroids first. That doesn't mean you just treat them and say, come and meet me after 6 weeks when your blood dose is 10 milligrams. Okay? You see them every week. And then you see them again the next week and the week after. And if you feel there's no new nerve involvement, or if the current third nerve is not getting worse, and hopefully it is some signs of improvement, maybe the doses from total doses have moved up to a partial, but now things are getting better, then you know that you're on the right track as far as treatment is concerned. If on the other hand, you don't find anything, patient has headaches, younger patient, you treat it with steroids, still not improving after 3 weeks or 4 weeks, within 3 to 4 weeks, some minor improvement, something should at least get better. If nothing is getting better, and the suspicions therefore are higher that something is being missed, then you have to do a BSA. There's no other alternative for that. So it's a combination of the situation, the age of the person, as well as response to treatment. So these three things combined together, and frequent follow-up is what is important.
Is there a window where you could say a 2-week period?
I wouldn't say that. I would.
You recommend?
I would base it on the symptoms. Suppose the person doesn't have any headache at all. I'm not really thinking of an aneurysm, and I would rather wait to see whether steroids are working in that particular patient. So it's better to wait. Since you spoke about now, just let me give you an anecdote. This was narrated by Dr. Joel Glazer, who is one of those authors of very famous books on neuro-ophthalmology. So Dr. Glazer had a lot of fellows with him, and he's trained a lot of neuro-ophthalm fellows. So one of the neuro-ophthalm fellows, many years later, sent an email to him saying that this was in the 90s, I think. I think it was in the early 90s. So he sent him a thing saying, I have this elderly lady with the third nerve palsy, and pupil is spared, etc., etc. So I'm starting her on this treatment. I've done an MRI with MR angiogram, which is normal. So Dr. Glazer is one of those people who's not eccentric, but is prone to quick bursts of anger. So he quickly wrote an email saying, what have I taught you after all these years? Complete third nerve palsy with total pupil sparing in an elderly person who maybe having little diabetes, hypertension. Why did you do this MRI and waste money? Is the question. So that guy actually sent back another email in response to this with an image attachment. And just to the question saying, now would you do MRI? So he opened the image, and it was an image of Barbara Bush, the First Lady of the United States. So those are other situations which tell you that you may need to cover up. Okay.
Well, do we have time for some more questions?
I think it's enough. We can close. Yeah, enough.
Thanks a lot, sir, for the wonderful session. And a pleasure having you here today with us to hear a wonderful talk and so much of illuminating information to all of us. So we again meet next month for a debate in glaucoma, which is going to coincide with the World Glaucoma Week. So that's going to be another interesting session as well. So we'll hope to see a larger audience for that session.